Okay, and I'll hand things over to Ashley.
Thank you, Patrick, and thank you all for joining us this afternoon for this conversation. Really looking forward to sharing some of our perspectives at Socially Determined and the work that we've had the privilege of doing with several of our partners around managing risk, improving outcomes, and advancing equity for Medicaid populations through social risk analytics. Our goals for today's session are really to do four things. The first is to share with you how leading Medicaid plans across the country are using social risk analytics to identify both community level SDOH needs for the markets that they serve, as well as person-specific social risk factors for their member populations. The second piece is really to talk about how these plans then can use that data to quantify the impact that social risk has on key performance metrics. So that includes things like suboptimal utilization, excess cost, quality measure attainment, as well as member engagement, satisfaction, and ultimately retention. The third piece is really how you then use those first two components to prioritize strategies and solutions to proactively and strategically support the social risk and needs of your member population. And then the fourth and final piece, which is really important, is to be able to measure results, to be able to track impact and make more informed decisions about investments that you make in social care programs and partnerships going forward. So looking forward to diving in to all of that with you this afternoon. As Patrick mentioned, you do have the ability to ask questions along the way. I promise this will be more fun and helpful if you do that. So please don't be shy about entering questions in the Q&A. And I will pause at a couple of points along the way to take questions and respond to them. And we'll leave some time at the end to dive into those as well. Before we get into the specifics around how plans are using social risk analytics, I wanted to take a moment to just anchor all of us around the why this matters, why plans are prioritizing this and investing in analytic solutions and strategies. And there are a couple of key data points that I would call out here. The first is that just the market opportunity here, when we think about the growth in managed Medicaid, is tremendous. And so all of you are probably focusing right now on thinking about growing your business, whether that is to net new geographies or increasing the number of attributed lives you have within your existing geographic footprint. But either way, we're going to see growth in this program. And so the opportunity to have a more strategic and analytics driven approach to managing performance within that line of business is going to be key for many of the organizations that I think are on the line today. The second piece is we're seeing real movement across many states around Medicaid agencies thinking about increasing the SDOH related requirements that they're including in their RFPs. So really seeing an evolution from screening focused requirements to more proactive, equitable and analytics driven requirements. And so it's going to be a key component for many of the plans on the line today around being able to meet those needs, both in the RFP process and once you're under contract. Third piece, and you're all choosing to join us today, so I think you're aware of this, but we continue to see, and there's clear evidence that up to 80% of the factors that influence healthcare utilization, cost, and outcomes are driven by things that happen outside of the four walls of a clinic or a hospital. And so really our goal in using this analytics first approach is to be able to open the aperture for your data teams and your operational teams to those other factors that are impacting your members and be able to be more strategic and equitable in how you identify them and address them. And then the other component here is that we continue to see some opportunities in the market around screening, but it's still pretty limited and it's not necessarily the most equitable way to understand the full social needs of your entire member population. And so it's certainly not to say that screening isn't a good strategy, but it's not the only one. And using an analytics first approach can really complement the work that your team or your provider network might be doing around screening today. So, with all of that said, what are the advantages of thinking about an analytics first approach to assessing and addressing the social needs of your markets and member populations? Really three key things that I would call out here for you all to consider. The first is it's a more holistic approach because it allows you to understand the contours and concentration of community level SDOH risk exposure for your full market footprint. In addition, it allows you to understand the individual level social risk factor needs for your full member population. And that includes members who might not be connected to care today. They might be unlikely to respond to a screening survey that you mail to their home. They might be unlikely to answer a phone call from an unknown number. And so without needing to reach them, you can understand their likely risk exposure and be more proactive in how you support those needs. Second piece is that it's more equitable because it avoids some of the barriers that have systematically excluded certain subsets of populations from some of those other strategies that we've used historically. And then the third piece, and this is really important, we'll spend a lot of time on this as we dig into the examples, but it's designed intentionally to be actionable. So our goal with applying an analytics first approach is not only to tell you which segment of your community and member population is at risk, but also what is the most actionable strategy that you could apply to effectively mitigate that risk. And we'll talk more about that when we get into our methodology. A little bit about socially determined for those of you who may not be familiar with us. So we are a full cycle social risk analytics provider. And to that end, we offer really two key things. The first is our SocialScape platform, which includes data around both community and individual level risk across multiple domains. And then also we've built a team of subject matter experts who can partner with your team to help you take the data and intelligence that we generate through that SocialScape platform and really translate it into your business strategy, operations, and importantly also for this work mission. And so to that end, we have the high trust certified, fully HIPAA compliant platform that's available to your team. We have a full suite of risk scores and other contextual data that we can offer as data packages that you can then integrate into your enterprise data systems, whether that's a care management platform or other. And then, as I mentioned, we have that team of experts who can help you take that data and the insights that we generate through our platform and really make it actionable for your teams. How do we do this in terms of the delivery component of it? As I mentioned, it's really important to us that we both provide the access to your team to our platform. So you can log in and surf around your markets and look at your member population and see what risk looks like. But also we want to embed that risk intelligence into the work that you're doing today. And to that end, that's why we offer the data as something that can be integrated into your enterprise systems. Before I go on, I'm going to pause for just a second and see if anyone has any questions about sort of big picture market trends that we're seeing around embedding social risk analytics into managing care for populations, or about what we at Socially Determined do to support some of those efforts. All right, I'm going to carry on, but don't be shy about jumping in if you have questions. So just a note about who we serve. So we primarily work with health plans across the country. That includes some national health plans, regional ones, and integrated delivery networks as well, and across all of their lines of business. So really importantly, SDOH and social needs are not just a Medicaid issue. We see this signal in commercial populations and Medicare Advantage as well. And so a lot of the organizations that we work with are applying this kind of analytics first approach across all of their lines of business. We also work with a number of providers, particularly those that are leaning into taking on more risk, and then support a number of organizations in the life sciences and pharma space as well. As I mentioned, our platform is fully HIPAA compliant, it's high trust certified, and we've been rated pretty highly for our services that we provide and the value we create for our clients by CLAS and other organizations out there that are rating solution providers in this space. I'm going to pivot a little bit and talk about from an analytics perspective, the data that we use and the way that we approach this work, because I think it's really important to understand the level of precision that's needed to make all of this really actionable. And so to that end, where we start is thinking about risk both at the community level and at the member level, and then also across a number of different domains. So really importantly, it's not just risk writ large, but it's risk specific to a particular domain that allows that information to be actionable for your team. So to that end, on the left-hand side of the slide here, you can see the different domains that we look at the community level. So that includes factors like the economic climate, the food landscape, housing environment, et cetera. And really, when we think about these models, we're looking at assets, infrastructure, resources within a particular community that influence the domains for the individuals and the residents who live within that space. In addition, though, we recognize that there are person-specific factors that can either accelerate or potentially mitigate that community level risk. So we also look, and you'll see on the right-hand side of the slide, across a number of different person-specific domains that relate to the community domains, but are built off of those models and enhanced by person-specific data that we can incorporate to account for some of those factors that might catalyze or mitigate the risk. And so to that end, you'll see we have companion individual risk factor scores for 5 of the 7 domains. And we're working on individual scores for those other 2 domains around the digital landscape and social connectedness as well. How do we build these risk models, and what data do we use to drive them is a common question that we get. So don't want to belabor this too much, but do want to make sure everybody understands that the way that we're building the scores is really by continuously harvesting and integrating into the SocialScape platform hundreds of different data sets. And that includes things that you would expect, like census data, CDC data, HUD data, FDA data, as well as a number of commercial and proprietary data sets. So we have information like point locations for every full service grocery store and fast food restaurant in the entire country built into the model. And that helps us understand what that food landscape looks like at the community level, as well as the accessibility of healthy and unhealthy food sources for individual members. All of that data that we're harvesting, we disaggregate down on the community side to a very precise geographic resolution, and we are able to build up from that our community risk models. To do that, we're able to kind of curate the most actionable intelligence around those particular domains and the way that that rolls up to curated and finished risk scores and intelligence. For all of these models, I should note, we use a 1 to 5 risk scale, where 1 indicates little to no risk and 5 indicates severe risk. And so it gives you a consistent view of risk and need across the community that you serve, the member population that's attributed to you, as well as all of the different domains that we look at on both the community and the individual side. I see that we have a question pop up, so I'm going to pause just for a second. And the question related to data sources. So as I mentioned, the data does come from a combination of open source and proprietary data sets. It's over 100 different sets. I should note that all of those data sets are being refreshed on their own cadence. And so part of the value that we provide through our platform is being able to pull all of that data in, disaggregate it, use it to generate our risk scores, and then visualize that within our platform in a consistent way, as well as provide it back to your teams through those data packages that I mentioned. That's a great question, so please keep asking. I wanted to take just a minute to dive deeper into one of our domains, just because sometimes some specificity helps. So wanted to take a look at both our food landscape model on the community side and our food insecurity model on the individual side. Starting with the food landscape on the community side, what you see on the left-hand side of the slide is summary of how we generate that risk score. So that incorporates 97 distinct data elements that are culled from a number of different data sources. And all of those data elements roll up into what we've identified as the 3 primary influencers of risk around the food landscape. And those influencers include the accessibility of food, the affordability of food, and food literacy within a given community. And just to give you a couple examples of some of the data elements that we look at to generate the scores, it includes things like average food budget within a community, the locations of healthy and unhealthy food sources, as I mentioned, vehicle ownership rates, right, as a proxy for the accessibility of food, and 94 other distinct data elements. On the individual side, when we talk about food insecurity, we think about the same three key drivers of risk: accessibility, affordability, and literacy. But we're actually looking at a number of additional potential data elements that can help us assess that for an individual member. So that includes things like their household food budget, their particular location and the density and ratio of healthy and unhealthy food sources around them, as well as location of, for example, transportation sites that can help them get to those food sources. So just one example of what the models look like for one of our domains. We have similar models for all of the other 11 domains. So once we have this data, how do we make it actionable for your team? As I mentioned, there's two ways that we do it. The first is through SocialScape, which is our on-demand dynamic decision support tool, an analytic platform that your team could log into. It allows you at the community level to surf around your market and see the contours and concentration of risk, which is what you see through the map. I mentioned that we have a 5-point risk scale. The way that that translates to the colors that you're seeing on the map is that the more saturated the color, the higher the risk. And so what you're looking at here is the food landscape distribution, as well as some assets within the community that we've overlaid. We do have the ability to overlay a number of different community assets, as well as your member population within this community risk visualization. So it allows your team to look at both the distribution of risk within your market, resources that are available that could help you mitigate that risk, as well as the concentration of your member population, all designed to really help you think through, from a geographic perspective, where are you seeing that concentration of risk and members in need? And then how do you think from a place-based perspective or a partnership perspective about assets, resources, organizations within that community that could help your team mitigate that risk? On the individual side within SocialScape, you can also view the risk scores, underlying drivers, and other related contextual data for your full member population. So you send us a member roster, we're able to generate these scores, and then your team can log into SocialScape and be able to filter, sort, identify the subset of your member population that faces the greatest risk for particular domains, understand what's driving that risk, and then be able to proactively reach out to them and engage them in some of the supports that you may have available. On that note, we do offer full integration with some of the community referral platforms that are out there. So for example, findhelp.org, if you're working with them, we have the ability to integrate the Find Help tool within SocialScape so that you can seamlessly go from a view of your members' risk to being able to look through that Find Help platform and identify resources that are available around them that might help them mitigate it. See, a question just came in about the risk scoring and the 1 to 5 rating. How is that determined? There is a weighting methodology that we use within it. So if you think about, the 97 distinct data elements that I mentioned that we incorporate into our food landscape score, each of those data elements gets rolled up into something that we call an engineered feature. So think of that as a calculated metric. So for example, it could be the distance and ratio of healthy and unhealthy food sources that I mentioned earlier. That then rolls up into that primary influencer of accessibility. And then across those primary influencers, we weight those to get to that final finished score of the 1 to 5. So it's a buildup from individual data elements to engineered feature to primary influencer to finished score. And that's how it works across all of the models. Great question. So more importantly, let's talk a little bit about how the Medicaid plans that we're working with today are using this information to really drive their strategy around proactively supporting the social needs of their member populations and optimizing the performance of the plan. And across all of the organizations that we're working with today, it's really 4 key things that they're doing. It's starting with identifying the risk for their entire market and their entire member population. And then being able to use that understanding of social risk to quantify opportunities. So where is social risk having the most impact on your members and on your business? And then once you understand that, it provides a really clear data-driven way for your team to prioritize action. So unfortunately, what we know to be true is that there's no shortage of risk and need. And so the value that we can provide and the way that we try and really guide your team is by helping you strategically prioritize. Where is there the most addressable risk? How do you start to build a roadmap to mitigate that risk? And where are you going to see the greatest return for those investments that you might make? And then really importantly, we also need to be able to measure results, right? Is this working? Are we generating a return? Are we moving the needle? And being able to use the social risk data that we have to help plans understand the return that they're getting for the investments that they're making and the opportunity that they have to make more informed decisions going forward about how do they scale, how do they sunset, how do they sustain some of those programs going forward, recognizing that you want to make the best use of the resources that you have available to support your members and to optimize your performance. All right, so I thought it might be helpful to share a couple examples of what this has actually looked like on the ground for different organizations that we're working with. And so for each of those steps that I just walked you through, wanted to share one example of what one of our partners has done to date around this, and then also importantly talk a little bit about where they're going. Because I should be clear that this is a journey, right? It's not a one-time analysis that you do, but it's really a building of a capability set within your organization that then leads you to a number of different actions that you can take, and really a process for being able to more systematically ingest and incorporate social risk into the work that you're doing across your business. So this is an example from the work that we're doing with Care First. For those of you who are not familiar with Care First, they're a regional Blues plan based here in DC. They operate in DC, Northern Virginia, and Maryland. And across those three markets, they have over 3.3 million members across multiple lines of business, including over 150,000 members in their Medicaid plan. Their focus really to date when they think about quantifying risk has been looking across that full market footprint and understanding the contours of social risk across that full population and that full market. And so that's where we started with them, generating individual level risk scores for their full member population, sharing that data back with their team, and then also looking from the community side at their three markets that they're serving and identifying subsets of that market where we're seeing a real concentration of risk across either a specific domain or multiple domains. And then that's allowed them to really understand the risk exposure, both from that community and the individual level, and think more strategically about how do they optimize the investments, the programs, the partnerships that they've already started to deploy to mitigate that risk and angle them towards the subset of their market and their member population that would benefit most from them. And then also think about where there are gaps. Because importantly, we see that there are always opportunities when you look at the data to identify needs that your members might have that you might not have on your radar today and be more proactive about thinking through partnerships, programs, and strategies that could help meet those needs. One example of that, we were looking at across their member population here in DC, and we recognized that there was a subset of their members that faced elevated risk across a couple of domains, and that helped them identify opportunities to more proactively support them. It also, when they were thinking about locations for a new wellness center, gave them the ability to look at need as well as member distribution, and from a geographic perspective, identify locations where they could place that center that would put them closest to members that would benefit from the programs and supports that were offered through that center. So think of all of this as a foundational view of where you can start to optimize your investments and strategies to make sure that when you're placing things like a new wellness center in a community, you're able to make that decision around location driven by data around your members' needs, as well as the broader community. I see a question came in. I'm going to pause just to answer that. Okay, so the question is actually about the integration of social risk data with clinical data. And I promise I didn't plant that question, but it tees up really nicely the next example that I wanted to share. So when we think about moving from just identifying risk to being able to proactively quantify opportunity, that's where the integration of clinical and social data becomes really powerful. So in this case, this is still from our work with Care First, but we were able to take a historical claims extract, so in this case, 3 years of claims data for their member population and integrate that with the social risk data that we had generated for them through the SocialScape platform. And that allowed us to identify cohorts of their members where we're seeing elevated social risk be correlated with excess utilization and cost, or quality measure attainment gaps, or member retention challenges. And so it allows the plan to understand, not just from an abstract social risk perspective, where is the greatest opportunity, but also from some of those other considerations as well. And so to share one specific example from that kind of analysis with you, when we looked across their full member population, we saw that if you control for demographics, geographic considerations, clinical acuity, and you really isolate on the members that have similar factors across those three domains, really where the difference is the level of social risk that they face. We do see consistently across their full member population elevated costs for members that are at higher risk. So across a broad base of their member population, it was about $3,000 PMPY differential between members that faced elevated risk versus otherwise similar members. When you look at particular clinical conditions, you see those PMPY differentials really increase in some cases. Now, I should mention that it's not the case that all clinical conditions are equally socially clinically susceptible. So it's important to focus on where is the most addressable risk and where are we seeing the greatest signal between elevated social risk and excess utilization and cost or poor outcomes across a variety of different clinical conditions. And so one example on that note is we looked in this case at a subset of members that were at elevated risk for both health literacy and food insecurity, who were diabetics, and specifically who lived in Ward 7 and Ward 8 here in DC. Now, it's a relatively small member population in this case, only 870 members, but across those 870, over 350 of them were at elevated risk for those two domains. And across that population, we saw nearly a $3,500 differential in PMPY costs. For the plan on an annual basis, that rolls up to over $1.3 million in excess spend. And yet, we know that there are programs in place within that community that can help meet those needs and start to tackle some of that addressable risk. And so to that end, armed with this information, the Care First team made the decision to invest in some community-based organizations through a grant program that was empowering those local CBOs who were already embedded in the community and already doing that work to be able to better meet the social needs of those members, as well as similar members within that broader community. So it's one example of how you can take that integration of social risk data with claims data to be able to, with precision, identify subsets or cohorts of your member population where you're seeing addressable risk, and then be able to strategically, either yourself or with local partners, invest in social care programs, interventions, and strategies that can help meet those needs and mitigate the risk. I'm going to pause for a second and ask if there are any questions about that. And I'm going to take a quick scan. All right, I think some of the questions that have come in so far are along the same themes. So data sources, how we generate the risk scores, and that integration of clinical and claims data. So I'm going to keep rolling, but if there are other questions that come up that aren't along those themes that I've already touched on, please do feel free to enter them into the chat. So let's talk a little bit about, once you have that social risk data for your full market, your full member population, you've integrated it with the claims data so that you can see where there is the most addressable risk. How does that for your team really help drive decisions and prioritize action? And this is to stick with the Care First theme, an example of how their team has started to do that beyond the initial placement of that wellness center that I talked about, beyond the focus on the members within Ward 7 and Ward 8 with diabetes who are at elevated risk, who they could better support by enhancing the capacity of those local CBOs. Another opportunity that Care First identified was there were a number of great programs, partnerships that they already had in place across a number of different domains. So things like financial coaching, also a workforce development, transportation benefits, and the referral network provided through their partnership with findhelp.org. So all of those things were already in place today. What they were lacking was a way to proactively identify the subset of their member population that would benefit most from those programs. So the advantage of taking this analytics first approach is it allows you to do that in a consistent way across the full member population, and then be able to curate cohorts or rosters of your member population that would benefit from each of those programs, and be more proactive about reaching out to them, making sure that they're aware of the program, helping them get enrolled, engaging them in a conversation around those needs. And so it's an opportunity to really optimize the impact that those programs are having across your full member population in a more strategic way. I should note also from an equity perspective, this is really helpful because we see systematically when we look at data around who typically tends to be enrolled in these programs, that it's often not the subset of your member population that would benefit most from them. And that's for a number of very valid reasons, right? They may not be connected to care today. They may not know that the program exists. They may not have the transportation or childcare that they need to get to the program. So being able to be more proactive about identifying them, engaging them, making sure they're aware, and then supporting them in terms of taking advantage of that program is a key component of getting the most value out of these initiatives, and really being able to drive impact across the most vulnerable subset of your member population. The other thing this will help you do is be able to identify gaps that you might have. So for example, if you're seeing that a high degree of your members are at elevated risk for housing instability, and you do not have a program or a partnership in place around that, it can help your team understand the impact that investing in that type of program could have, and the need that you have across your member population. Fourth and finally, really important to make sure that we also talk about the measurement component of this. I would say in our experience, most of the plans that we start working with have invested in a lot of great programs to date. They often lack any ability to understand whether those programs are really generating ROI and improving outcomes for their members. And so the other advantage of applying social risk analytics is it allows you to look across that full portfolio of programs and interventions and understand in a consistent way what's really moving the needle around outcomes, and how should you think more strategically about investing in the programs that are working and making adjustments candidly to those that are not. And so to that end, I wanted to share a little bit of the work that we've done here in DC with AmeriHealth Caritas, one of the 3 managed Medicaid plans in the district. And when we started working with them, they had a portfolio of 12 different social care interventions that they were already deploying to their full member population, but without visibility into which ones were most beneficial. And so our ability within the SocialScape platform to integrate not just the social risk data and the claims data, but also programmatic data from those different social care interventions to create a holistic and consistent picture of impact across that full portfolio. And so helping the team understand across a number of different measures, where are they seeing the most return, both across all of the programs together, which are the numbers that you see on the right-hand side of the slide, as well as for each individual program. So when we looked across all of the programs, what we saw, and I think hopefully the most encouraging thing for the folks on the line today, is that they are actually having an impact, right? 37% reduction in 30-day all-cause readmissions across all programs, 36% reduction in EMS visits, 26% reduction in low acuity ED utilization, and really remarkably 33% reduction in inpatient visits. That's averaged out though across all of the social care interventions. What we see when we look at the individual interventions is much more variation. So to give you one example on that front, we looked at 2 relatively similar food insecurity related programs, and we saw that one of them was having almost a 40% impact on low acuity ED utilization, and the other one was less than 10%. So from the plan's perspective, as they make decisions about investing in those programs going forward, it makes more sense for them to think about scaling the one that's driving outsized impact rather than continuing to invest equally in them. The other opportunity here is thinking about tuning the design of some of the interventions that are not as impactful today. So it could be that there are components of the program that are not optimized for your member population. And so being able to understand that and think with your local CBO partners, with your intervention partners around, are there adjustments that we can proactively make to the program that's going to allow it to be more impactful? It's another opportunity that we see with this kind of impact analysis. You see that one generated a lot of questions. So I'm going to pause for a second and take a quick scan. So one of the questions here is about working across Medicaid populations in total, or across the full market or at the state level. And so that is one thing that we see a lot of opportunity around, and certainly where some states are going in terms of their requirements of plans. There is the ability, right, to create a consistent view of risk and need across not just your member population, but all Medicaid members within a state, and work more collaboratively around investing in interventions that can help meet those needs. So we see a lot of opportunity there. We certainly think that's where, from a policy and regulatory perspective, at least some states are likely to go, and would encourage you to think about, if that's likely the case in your state, how do you start to get ahead of that and build these internal capabilities around analytics and impact evaluations that would put you in a position to be really a leader in that as the state starts to move forward with increasing regulations around how plans are addressing SDOH, both as part of the RFP process and quality measure components of the contract. Okay, so just, I hope those specific examples help. I don't want anyone to think, though, that those are the only ways that social risk analytics can be deployed. So wanted to spend a minute just to talk about the different types of questions that taking this analytics first approach can help your team answer. So it's things like, which of your communities and members are most impacted by risk? We've talked about that a lot. That helps you from both a place-based perspective and a member-specific perspective understand where you should focus your investments and energy. It also can help you answer the question, how do you provide more proactive and holistic support? And that can impact a number of different ways that you're engaging with members today. So if you think about, for example, your care management team that's reaching out to members, if they understand the social risk profile and needs of your members, not just their clinical needs, they can have a more engaged, holistic, comprehensive conversation with them as part of the care management outreach and engagement that they're already doing. In addition, it can help you understand, as I mentioned, which of your members would benefit most from those programs that you have in place today, and not just the ones that are most likely to find their way to those programs independently. So think about getting upstream of that and being able to be more strategic in identifying who would benefit from these programs and proactively reaching out to them in a way that's tailored to their needs and allows you to be more likely to be able to engage them and enroll them in those programs. And then finally, as I mentioned, the ROI piece is really important. So is this translating to value for you? Is it translating to value for your members? And how does that help you make more informed decisions about the investments you make going forward? To that end, I wanted to spend just a minute talking about the data component of this, because this is a common question that we get, as we think across the different types of social risk data and analytics support that we can provide for your team does require differing levels of data from your end. So I'm going to start at the top here. At the highest level, the community level data that we have within the SocialScape platform is available for the entire country across all 7 of those domains that I mentioned at a really precise resolution. So sub-county, sub-zip code. It's actually a 200-meter unit of analysis. So it gives you a really fine degree of granularity around the contours and concentration of risk. All of that is available within the platform to your team without any data required. That allows you to establish that common view of risk across your full market. We can overlay on that specific facility location. So if, for example, you wanted to overlay your provider network, that's something that we can do. But it's really all designed to give you that common view of risk and inform your place-based interventions strategy and your community partnership strategy without requiring any data from your team. In addition, with just a patient or member roster, we're able to generate those individual level social risk factor scores across our 5 domains. So don't need any more information than that member roster to be able to generate those scores and give you a consistent view of risk across your full population. That helps you, as I mentioned, both identify and prioritize individual members as well as cohorts of members that would benefit most from social care interventions and support. Third piece is that integration of the clinical and claims data that really will allow you to identify the subsets of your member population where elevated social risk is having the greatest impact. And so those are the measures around, excess PMPY or quality measure gaps or member retention challenges. And so being able to connect the social risk data with the quality data, with your claims data to be able to proactively identify, where is it having the most impact on your business and how you prioritize the actions that you're going to take to start mitigating that risk. And then the fourth piece is the programmatic data, right? So when you do invest in those programs or the ones that you're already investing in today, how do you understand where you're seeing a return and how do you use the ability to connect social data, claims data, and programmatic data to provide that comprehensive view of ROI that's going to drive your strategy going forward. All right, so with all of that said, I'm going to pause there and let people ask questions. I'm happy to dive into any of the areas that we just covered that would be of interest to the group, anywhere you want to dig in a little bit deeper. I'm going to scroll through the Q&A while we do that, but hope some other questions will come in. So there's a question about metrics and how organizations are quantifying success. Really important question because of what I would say is across the plans that we're working with today, they have different definitions of ROI. And part of it depends on the time horizon that they're looking at. Part of it depends on the quality measures that they're focused on right now. And part of it depends on the strategies that they're deploying. So to give you a couple examples, one of the plans that we're working with right now, which is a regional Medicaid plan based in the Midwest, for them, where they started was using social risk intelligence as a way of understanding for newly assigned members where they don't have a claims history to rely on, what does their social risk profile look like early in that relationship? So thinking about first-year members and understanding from a social perspective, how can they best engage with them early in that relationship and support their needs? The theory there is that by doing that early and more proactively, they're going to be more successful in engaging members and more likely to drive first-year member retention. And they know that if they're able to keep a member for 1 year, they're likely to keep them for 5. So for that particular plan with that particular strategy, the key driver of ROI was first-year member retention. On the other side of it, we work with plans that are focused on things like HEDIS measures. So when you think about low acuity ED utilization or 30-day all-cause readmissions, there's clearly an opportunity to move the needle around those types of quality measures using this type of data and this analytics first approach. Total cost of care is always popular. It's always going to be on the list, but I would just caution you all to think about a more holistic subset of measures that you might use to define ROI, given that one in particular, we do see it takes a little bit of time to move the needle on. So I would want you to think about ROI, not just in the context of total cost of care, but some of those more proximal utilization measures, quality measures, member satisfaction, engagement, retention measures as well, that will help your team understand where you're starting to see a return.
Okay, looks like we got another question in. Oh, couple.
Let's see. Patrick, do you want to call out, are there any ones that I missed? I know there's so many here, it's hard to.
No, you're up to date, though. 2 more came in, and I'll put that in the chat for you.
Okay, great. So there's a question about the reduction in readmissions and that comment that's really impactful. Yes, it really is. And so the question is just to elaborate on that a little bit more. So one of the interesting things when we dug into that particular measure a little bit deeper, we saw that when we looked at the members historically who had a 30-day all-cause readmission, when we looked across the different social risk domains, we saw that food insecurity in particular and transportation barriers were two that were highly correlated with an elevated risk of a 30-day all-cause readmission. And so from the plan's perspective, they were able to think more proactively about, okay, for members that are being discharged, that we know face elevated risk of either food insecurity or transportation barriers, can we proactively connect them to, for example, a medically tailored meal delivery program or a transportation benefit that would help ensure that they get to that post-discharge follow-up visit that's going to make them less likely to get readmitted within 30 days. And so that's a really nice one for us because it's a defined population. You can, as part of the discharge planning process, proactively identify the subset of your members that face elevated risk for those types of domains, connect them to those services prior to discharge. And we see that it really does make a difference around moving the needle around readmissions.
Okay, any more questions? You still have some time. One came in.
Patrick, did you put it in the chat? I'm sorry, it didn't refresh for me.
Oh, just did it. Got another one too.
Oh, the question is, do we have any use cases around working with health systems or payviders? Yes, absolutely. So one of the things that we've seen is that when you think about organizations that are most well positioned to be able to act on this kind of intelligence, there is a real opportunity to partner with your health systems and with, especially if you're an IDN, to work with the provider side of your organization to use this information to really be able to drive intervention strategies and proactive support. And so to that end, for example, we've worked for several years now with ProMedica and their health plan Paramount around looking at their full both patient population and member population, understanding risk, and then being able to think about from an intervention perspective, how do we tee up intervention strategies and partnership strategies that can really support performance both on the provider side as well as on the plan side. I'll give you one example there. So we've analyzed over 1.1 million unique ProMedica patients and Paramount members. And across that population, we've surfaced cohorts where we're seeing that correlation between elevated social risk and excess utilization and cost. And then ProMedica, as many of you may know, has developed a really robust portfolio of social care interventions that they are offering to their full member population, but our ability to really strategically drive enrollment in those programs has been something that's really helped them get the maximum benefit out of those programs. I'll give you one example of that. We looked at a population that faced elevated risk for financial strain, and they have a really robust financial opportunity center model there based in Toledo, where they're doing financial coaching and building financial resilience. And so we've curated for them a list of about 1,500 members within their market that are at elevated risk of financial strain and have a chronic condition that is disproportionately impacted by that strain. And then allowed those financial opportunity center coaches and outreach members to proactively reach out to those members and try and get them enrolled in the coaching program. And we've seen that move the needle, not just on some of the clinical and utilization measures that you would expect to see. So similar results around 30-day all-cause readmissions, low acuity ED, connection to primary and preventive care too. So it's not just about types of care that we're trying to avoid, but also types of care that we're trying to really encourage. But also importantly, seeing real movement around the financial resilience of those individuals. So material increase in average credit score, material increase in average income on a monthly basis. And so just another example of how when you have the ability to work together, whether it's within your own network or with local partners in your market, the ability to use this data as a way of driving some of that action is where we see the greatest opportunity and impact.
And we did get another question.
Okay. So the question is, so are we at Socially Determined focused on the analytics piece? Do we also make referrals? So we are exclusively focused on the social risk analytics part of this. We work with a number of the different social network referral providers. So I mentioned the work that we have done around Find Help and the integration that we have within SocialScape, our platform, and Find Help's platform. We work with other providers in that space as well. So if you're today working with a referral network, we can integrate that in a seamless way so that you're able to take our analytics and data and be able to infuse that into that referral network in a way that's going to make your teams that are doing those referrals able to work seamlessly across both systems. So another question around the closed loop component of this, and particularly around the CBO side of the data, which is a great question. So the work that we have done around program evaluation, impact evaluation, as part of that, we have partnered with a number of different CBOs to get that programmatic data. And in some cases, we're able to get it directly from the plan. In some cases, we're getting it directly from the CBO. But it is important that to be able to do the full cycle impact evaluation, to have both not just only referral data, but also referral and fulfillment data. So for the referrals that you're making to that financial opportunity center, how many of those individuals actually show up? And do they go through that full intervention program as it's designed? And then our ability to use that referral data to sort of drop a pin, if you will, in that claims history that we're looking at and say, okay, we have this baseline period of utilization and cost data before that social care intervention happened. We have the intervention period itself, right, where we're supporting that individual. And then we have an impact period after that, where we're hoping to see movement around those utilization and cost metrics that we're looking at. And so we have the ability within our platform to look at those different periods and be able to identify the impact around those interventions, recognizing that the programs are all enrolling on an ongoing basis. And there is an intervention period that's a key part of that evaluation strategy that we need to incorporate as part of the work that we're doing around quantifying impact. Patrick, are there other questions that have come in? I know we're running short on time, but we do have a few minutes left if folks have any left.
Yeah, and I'll just read this. Is there an optimal plan size for it to make sense to work with you? If a plan is small, 50,000 members or less, is that okay? So I guess it's the size of the plan this person's interested in.
Yeah, absolutely. So it's a great question. And we work with plans of all sizes. The smallest plan that we work with had around 30,000 members. And we've worked with plans that have, multiple millions of members. What is true, no matter what size population we're working with, is that we always see that there is, a subset of that member population that are going to face elevated risk, and that there are things that you can do as a plan to better support the social needs of those members. So whether it's 30,000 or it's 30 million, the opportunity for you all is to be able to, with precision, consistently understand what risk looks like across that full member population and strategically start to deploy resources to be able to mitigate the risk.
Okay, perfect. I think we're about at the end here. No more questions. Ashley, hey, you did a great job. This is extremely beneficial. And I think that's evident in the amount and the quality of the questions we received. I know I learned a lot today and a lot of good take-home knowledge. And as a reminder, you can ask additional questions. And if you want the slides, Ashley's email is right there. Simply contact her, or MHPA will help you out, of course, to get those slides if you are interested. Also, this will be recorded, or is being recorded, will be on our YouTube page. So that's another way you can access it, send it to your colleagues, etc. And then finally, don't forget, you can meet Ashley, MHPA staff, our health plan members, of course, is Phoenix. This September in Phoenix for MHPA 22. Hope to see you there. And with that, I want to thank everyone for your time this afternoon, and we'll see you next week for another valuable webinar. Thank you, Ashley.
Thanks all.